Beth, you mentioned immunotherapy and chemotherapy together for non-small cell lung cancer. This is an exciting area. We're at ASCO and we're going to hear lots and lots about immunotherapy. What's your experience with CINV as it relates to immunotherapy?
Yeah, so I initially thought, wow, why would immunotherapy cause nausea? But if you look at these drugs, even as a single agent for the PD-1 and PD-L1 inhibitors, they report up to 20–30% of patients having some grade of nausea with them. And I can say clinically I have seen some of that. It's interesting because they would be listed generally on the low emetogenic threshold for the NCCN or the guidelines. So typically that would say, oh, you could give them a low dose of steroid, but I wouldn't want to do that really with immunotherapy. Probably wouldn't hurt for one day, but probably not my first drug of choice. So I traditionally don't. So I don't traditionally give antiemetics prior to the IV immunotherapy treatment, but I have had to sometimes. I think the other thing, now immunotherapy plus chemotherapy is a whole different ballgame because then you're treating the nausea associated with the carboplatin. So I
So
don't.
are you giving steroids in that case? Because that's a debate when you're giving a PD-1 as monotherapy, but now you're adding chemo, and of course it's got carboplatin plus another agent. So
Correct.
What's your thoughts on that?
Yeah, so if you look traditionally at the guidelines, you would give a steroid. Adding in the immunotherapy wants you to shy away from the steroid. However, I don't think that one low dose of dexamethasone especially is going to dramatically change the outcome of the immunotherapy. Now, I can say that theoretically. I don't know that. There's no randomized data to support that. So can we shy away from the dexamethasone? I can tell you in clinical trials it was really up to the practitioner. So you could prescribe dexamethasone with the chemo plus immunotherapy, or you didn't have to. In our case, a lot of times we didn't. We would just give maybe a 5-HT3 or NK1 together and eliminate the dexamethasone, just again because of the theoretical idea that it may counteract or be counterintuitive to the immunotherapy drug. However, do I think that, especially if a patient is at high risk, do I think that 8 or 12 milligrams of dexamethasone one day is going to dramatically decrease the efficacy of the immunotherapy? Probably not. And I can tell you that several of our patients, especially with brain metastases, or patients with COPD that I treat who are on prednisone 10 milligrams every day of their life because they have to be, that doesn't automatically make me not give them an immunotherapy. So we have treated patients who are on low doses of steroids with immunotherapies successfully. I don't have any randomized data to say that that's a bad thing, but it can be done safely, I can say that. So I think that's going to be up to the user. I think that's going to be up to the physician or the NP or the clinical pharmacist to make a recommendation on whether or not they need the dexamethasone as that cornerstone of therapy for the antiemetic.
I always get into the issue, and I've had this issue with our physicians in some cases about the use of dexamethasone in certain patients, aside from immuno-oncology drugs. And the question is, gee, I have a patient who has issues with glucose. Do I want to give them that dose? And had to pull data from various studies to show that it didn't really make a difference for a small dose for a small period of time, or even a large dose for a small period of time. The question I always have is, can you show me a study with antiemetics that doesn't use steroids? And the answer is, I don't really think so.
No.
So all those results are the combination of two. So when you take the steroid away, are you really giving me effective therapy or not? I would have an issue with doing that. I don't know what the answer is,
right,
but I have an issue with it. We've told our physicians, and they've basically backed down and said, okay, we give them the appropriate therapy. If we're giving them control of CINV and it needs dexamethasone, we give them dexamethasone. And we don't worry about that going forward. The combination for lung now with immuno-oncology, gets you into that whole other area, and I don't really know the answer, although I suspect that, as you suggest, a dose or two here isn't going to make a difference.
These are real boots on the ground kind of problems that we're all facing. And for me, I really think about patient risk factors, and if all those risk factors are there, I'm more aggressive, in having that conversation.
So the patient that I treated yesterday is a great case example. So she has bone metastases that she just finished up radiation, was in tremendous pain from the bone metastases. She's currently on 4 milligrams daily of dexamethasone for the pain control. We're tapering her off as quickly as we can, especially since we're starting an immunotherapy drug. But so I didn't add dexamethasone to her antiemetic regimen yesterday because she's actually already taken 8 milligrams in the past 24 hours of dexamethasone. So at that point I'm saying, there's no reason for me to add additional, and we're going to taper you off as quickly as possible. But there are so many reasons that they may be on dexamethasone already. It's not a contraindication, is what I'm trying to say, to starting the immunotherapy. But I think as a general rule of thumb, patient risk factors, how much utility do you think are you getting out of the dexamethasone, especially for that one day of the day of treatment, and make your decision based on that.
Nausea with immunotherapy, though, can be very complicated too, because it could be an early sign of an endocrinopathy. So it would be really tough to potentially differentiate whether it was pure nausea from a nausea standpoint or if an early sign of a side effect.
Right, so we have a whole new era now that we have to get comfortable with. We need more data. It'd be very interesting to go back to those trials and see if we could do a subgroup analysis between those that got Dex and not in terms of what their CINV results were. So I think we have a lot to learn.